majority of our patients were female, at a percentage of 51.7, and majority were from rural residents for the demographic data. And for the clinical factors, most of our patients that developed post-stroke seizures were patients that had hemorrhagic stroke, as we are going to see. So this first diagram basically looks at the age distribution, and as you can see that most of our patients were actually less than 50 years of age, followed by at 37%, and then more than 71 had a percentage of 27%. And then if we go to the age, this we mostly looked at it to be a 1-to-1 ratio because the females were slightly higher than the males, so it was 51.7% and 48.3%. Then also the patients that had hemorrhagic and ischemic stroke, as you can see, it's also almost a 1-to-1 ratio. And then for the stroke severity, most of our patients had a moderate to severe stroke, as you can see from the diagram. So the other parameters that we looked at as well was the glaucoma scale, the alcohol and substance use, and 24.9% of our patients were using alcohol and 31.3% did not have any formal education. So the next diagram helps us look at that. So our median GCS scale was 12, an interquartile range of 9 to 14, and as you can see that most of our patients had cortical involvement, 32.8%, and most of our patients as well had unilateral stroke. But as you can see to the diagram on my left, most of our patients had stroke lesion location in the parietal mostly, followed by intraventricular, the frontal, temporal, and the least were the brainstem and the insula, and then the thalamus. So most of our frequent locations were the parietal and the intraventricular, as well as the frontal, as you can see. Going on to the first objective. So our incidence of stroke seizure overall was 28, or 38 was 28.4%. So from the 201 participants that we enrolled, 57 of them developed post-stroke seizures. And as you can see to the diagram on my left-hand side, it was the ones who did not develop were 71.6%. And for most of these patients, like I earlier alluded, their seizures occurred early, within 0 to 7 days. So about 80.7% of our patients developed their seizures between day 0 to day 7, and the minority developed their seizures after day 7. So the cohort actually had a high 30-day post-stroke seizure incidence compared to other studies that have been done in our setting that we're going to see in the next slide. So that means 4 of every 5 seizure events occurred within 0 to 7 days, making the first week actually the highest yield monitoring window. So we don't know if this was because our study was prospective and maybe it could have captured more seizures compared to the other studies that had been done that were actually retrospective studies. But also the higher percentage of hemorrhagic stroke in our patients could have overestimated the incidence, given that from literature there are more patients, all the patients with hemorrhagic stroke are at a higher risk of developing stroke seizures. So this is just a summary snapshot of our overall criteria incidence of stroke seizures, and 80% is just a summary of what we talked about. and then our adjusted relative risk was 1.48%. So that means our strongest independent predictor of post-stroke seizures was hemorrhagic stroke, and there was 48% high likelihood patients with hemorrhagic stroke to develop post-stroke seizures. So now going into the other subgroup signals, crude signals, this was before we adjusted. So we tried to look for also the other predictors of post-stroke seizures, and before we adjusted, we found that post-stroke seizures developed in 35% of patients with hemorrhagic stroke versus those, could someone help us with the charger for this one? About to close down. Thank you. Compared to the 22.4% one ischemic stroke. And before we adjusted the male patients, male sex and mortality showed a higher crude seizure rate, but this did not establish independent prediction after we adjusted, after the multivariate analysis. So they still, like I earlier alluded to, our strongest independent predictor of post-stroke seizures was the hemorrhagic stroke, and the adjusted relative risk was 1.4% with a p-value less than, with a p-value of 0.045. So that means statistically significant after adjustment. So that means patients with hemorrhagic stroke are 1.4 times more likely to develop seizures compared to their counterparts with ischemic stroke. So the clinical implication for this, so after adjustment, male sex was not significant, as well as the mortality that occurred within 30 days. So clinical implication, that means high-risk flagging should prioritize patients with hemorrhagic stroke, especially during the first 7 days presentation. So how do these findings compare with the current literature? Like you see, as I earlier alluded, the Ugandan cohort now sits at the top with the highest percentage of 28.4%. The other studies that have been done in Africa are in Ethiopia and in West Africa. And in Ethiopia, a study that was done by the Neurology and Italy in 2023 found a prevalence of, an incidence of 32.2%, and as their strongest predictor of post-stroke seizures was hemorrhagic stroke, cortical involvement, male sex. However, their age group was more in the patients that were younger, patients that were less than 40 years of age. There was one that was also done in West Africa in 2021 by Sapo et al. That showed 14.9%, and another that was done in Singapore that showed 6.6%, as well as another that was done in Italy that showed 2.3%. So what's the main message here? The 28.4% incidence found in this cohort is higher than other reports that have been done elsewhere. So the most possible reasons that we could attribute to this could be probably, like I earlier alluded, the high proportion of hemorrhagic stroke, and also the fact that we did a prospective study. Most of these studies were doing retrospective studies, and so that could also explain that maybe we captured, since we're doing a prospective study, we captured more seizures compared to the retrospective studies that could be subjectable to recall bias. So also the fact that most of our patients had moderate to severe stroke burden with a median NIHS score of 16, and also the fact that our study was carried out in a tertiary facility. So it's possible that we receive more patients that are quite ill, the patients that have been elsewhere, and by the time they come to us, they're actually quite ill. So, and also the resource limited setting that we are in could contribute to the delayed presentation, and also the fact that most of our patients cannot afford the diagnostics early enough, so they present with much severe disease. So what does this mean for our practice in Uganda? It's important that we identify patients who are high risk very early, like our study alluded to, patients with hemorrhagic stroke should be flagged. Patients with moderate to severe stroke should be flagged, and a high index of suspicion as closely followed up, as well as patients with cortical involvement. And that means in our radiological imaging, we should ask for the radiographers to also report about cortical involvement, because in our setting we found that most of it is actually not reported. So it will help us be able to closely monitor these patients and be able to take action. Intensify our monitoring, especially in the first 7 days, use a structured seizure checks and caregiver education and peer documentation. Like the previous speaker alluded to, one of the things that you can use to actually identify these patients are the care and the select score, care for hemorrhagic and the select score for the ischemic stroke, which we did not use in this study, but it can also help us to identify the patients who will be at risk. They treat selectively. This was talked about very well, and I was glad that the house was very interactive. So primary prophylaxis is not recommended, as well as secondary prophylaxis. Treat witness or strongly suspected seizures promptly, and routine prophylaxis and seizure medication for all stroke patients is not supported by that current evidence. So most of our seizures were diagnosed clinically, like the International League of Epilepsy recommends, but since we did not choose the EEG, there is a possibility that we could have missed the non-convulsive seizures. Apologies for this study, I don't know what happened. But the strength of this study, which was a prospective design, defined as with a 30-day follow-up, and it was carried out in a tertiary facility. So this could easily be generalizable for Uganda. And some of the limitations for this study, it was a 30-day follow-up, so it may underestimate the later burden of the late seizures, which is actually more concerning, because these are the patients that are going to progress for stroke epilepsy, and they need to be on lifelong treatment. So we relied a lot on self-reported seizures from the patients, the attendants, and the research staff. So it's possible we could have missed out a few, and we did not carry out routine EEG confirmation, so we could have missed out on a non-convulsive, and it was a single tertiary center sample which may overrepresent severe stroke, like I say. Since it's a tertiary facility, it's possible that most of our patients who come to the center have been everywhere else, and by the time they reach us, they are quite ill, and limited evaluation of other causes of seizures in acute stroke. We could not look at everything, but we looked at the most common ones like hypoxemia, hyponatremia, sepsis, mostly. So we did not go through the whole spectrum. So in conclusion, more than 1 in 4 patients with acute stroke can develop post-stroke seizures within 30 days of our follow-up, and 4 of every 5 seizure events occurred within the first week after the stroke. And hemorrhagic stroke was the dominant high-risk hemorrhagic stroke, patients to see maybe what most patients in our setting would respond to. Although, like we earlier alluded, the most recommended medication that has been studied a lot is the tiracetam. Thank you so much. My references.
Thank you very much, Bana. Another round of applause to Bana for the presentation. Yes, so she has done research about what Dr. Isaac took us through, and I believe we can relate to her work. At this point, we shall welcome questions to her about the study. Yes, we shall start with Dr. Kajum here.
Thank you, Bana, for the presentation. I'm inquiring whether could the high incidence also be biased by the reporting bias? How did you correct data seizures. How did you collect the data on post-stroke seizures? I'm inquisitive whether there is some sort of reporting bias.
Okay, another question? Dr. Kaira?
Thank you, Bwana. Mine is an inquiry looking at what they have presented previously. Is it by, did you also look at the data, like for example, for those patients that were being treated, like for example, the commonest drugs used in our setting, and maybe after patient getting the anti-seizure drugs, getting another seizure after that, just an inquiry whether that was also part of what you collected. Thank you.
Any other question from our neurologists? Okay, so yeah.
Thank you very much for your presentation and for the great work done. I guess mine may not necessarily be questions, but maybe just comments. Maybe you need to define for us what exactly the seizure was. What did you regard as a seizure? So we can then better understand what the attendant saw, what the patient felt, what the research actually found. Then maybe if you could just show us your objective, your recommendation number 2. Just go back again. Back. There's a bit where you talk about recommending structured, I think it was, yes, use of structured seizure checks, caregiver education, and peer documentation of events. I'm not too sure whether you looked into whether these were issues in the data you captured. So you want to use these tools, maybe you should develop a structured seizure check. Recommend that a study develop a structured seizure check based on what you have found. These imaging findings, this patient report, this. Because I'm not too sure you had the actual information to show that the caregivers were uneducated. Because you went ahead, this shoots you in the foot in that you went ahead to ask them, did the patient have a seizure? And they said yes. And now you're saying caregiver education. So did they know what a seizure was? You understand? So it becomes a bit of a gray area for you. So I would say that you have some information on some of these things that you found. Maybe you want to try to recommend someone come and test out a score. The scores that have previously been mentioned in other settings. Maybe we can develop one for our own setting here. Thank you very much.
In the same way, not stroke, apart from seizures, someone had talked about other movement disorders that can happen depending on where the stroke was. That can move very closely, like seizures, if you teach your basal ganglia, dystonia, and all those things. Clonus. And then those are very hard, even for us, to sometimes speak out what is a seizure and what is not. So to people, when you put neurology, if someone asked you, would there have been other confounders and you overcall it? So I think just, if you're very sure that you looked out for those that indicated, whoever was giving the information, aka the parents, the medical staff, just put that out so that it cancels that gray area, so that people know, yes, we need this neurology that was reported as seizures, and we didn't overcall other things. And then there is a limitation that you put, your limitation number 4, where I think you're cheating yourself a bit, but also the information that you can give. You said that there are no routine EEGs were done, seizures were clinically diagnosed. Seizures are actually clinically diagnosed. That should not be a limitation. EEG does not diagnose seizures. it supports us maybe to localize and all that. So maybe later when we want to use, maybe you can just comment, we could have lists like some clinical seizures, because the one written EEGs for those in ICU. And yes, for all of us, epilepsy, seizures, clinical diagnosis. EEGs, supportive. So if you take history and look on this, it's a seizure. Incident, send for an EEG. We have few resources, we should list them. And then remember that up to 1 to 4% of people with epilepsy have what? And even people that are new, if you did an EEG now, you're going to catch 3% of us with for activity. 10% will have no more findings. So we need to use the EEG responsibly. Thank you.
Okay, I don't know if you have any other questions. But in the interest of time, I think we shall allow Bernard to respond. However, I don't know if they brought an EEG right now and they requested us to volunteer. I don't know how many of us would accept. Over to you, Bernard.
Thank you so much for those insights, especially the add-on points. So to maybe answer some of the questions. So for Dr. Kajino's question, so for the patients, we define seizures as transient episodes of uncontrolled abnormal electrical activity in the brain that will result in changes in consciousness, behavior, memory, or feelings. So we educated the attendants as well as the research assistants for all the subtle changes, including the lip smacking, abnormal movements, and also like the earlier presenter alluded to, like most of the stroke seizures are actually going to be focal. So that made even our work quite easier. So the patients that we were not so sure if we had actually had seizures, especially from unclear explanation, we did really consider them as seizures. And then also we did routine monitoring at least twice a day, and that helped us to actually be able to pick up most of the seizures. And then Dr. Kaira, just a part of your question.
I know it is not part of your objective, whether like you looked at the commonest drugs the patients were receiving as seizures.
Thank you. So we looked at some of the drugs that the patients had been on, but given that our study concentrated mostly on acute stroke patients, we didn't consider patients who had recurrent stroke. So most of our patients, as they came into the hospital, were actually not on any anti-epileptic drugs. So, but there are some that were studied and we're still analyzing that data and can share it at an appropriate time. But most of the common drugs that most of our patients had been started on, especially the ones we did not get on day 0, and they were started prophylactically on Venetone and carbamazepine. Yes, and then maybe to answer Dr. question, yeah. So some of the scores about caregiver education, we actually have a template of what we have a template in form of a phone script where we were educating the patients, the caregivers, the research assistant, on what exactly we should look out for. So maybe I can share that. And then our study did not include the scores, the CAPE scores and the SELECT scores. So maybe that would be something to consider for a bigger cohort. Thank you so much for that comment.
So, sorry, my comment was that you found some information.
Yes.
Could that be turned into a score?
Yeah, that's a very good suggestion.
Okay, so someone can come and do a study which looks at if this score can pick out, and then we then have a score.
So it will be a de novo score.
Yes. Then the other one was just add to the definition, because that as Dr. Teresa has already said, it's going to either help you or add to a limitation Because if I detect an abnormal movement as a seizure,
Yes, in this presentation, I did not include our definition, but it's definitely included in the work. I just kept talking about the definitions as I went along.
Thank you, Bana. It was a great presentation indeed. And I hope you use the questions that have been asked to better your write-up. I believe you will make an excellent write-up. Okay, as we try to load the next presentation, we want to take this opportunity to recognize the presence of Professor Kadu. Prof, you're most welcome. It's a pleasure having you with us. Yes, I think there's an association. I don't know if that would be a correlation between the name Kadu and neurology. I don't know if that is a correlation, but it's a pleasure having you. All right, so we shall go right to our next presentation, and that will come from none other than the president of the Neurology Federation of Uganda, Dr. Kadu Martin himself. So there's a difference between Dr. Kadu Martin and Dr. Kadu Mark. Can I challenge someone here to tell us the difference between the two? I've always had it in the corridors, so I said, Dr. Kadu, then they say, which one? So, okay, but I think we shall go right into our presentation. Over to you, Dr. Kadu.
I hope by the time I finish my presentation, the differentiation of the sometimes things which are obvious are hard to distinguish. Colleagues, ladies and gentlemen, I'm here to just run through what has already been said, and to remove that so that you don't scare others. So I'll just go through some few things, highlights might not be everything, but just some few updates on epidemiology. I'm happy Dr. Bena has presented something, so it's showing us a picture of what's happening in Uganda. But we'll look at the bigger picture, pathophysiology, just 1 or 2 points and some few evidence of things which have been said. I have nothing to disclose, apart from myself here. And we know that the cerebrovascular accidents are accounting for around 50% of the adult epilepsy that we are seeing. Either some is hidden, or some we just find it on the ward. Somebody said I'm having seizures, but in the long run, for those who have been practicing or even seeing other patients, you may see CT scan, MRI, and then you just see somebody had a silent infarct, and then maybe explain the stroke. And of which around 2 to 14% tend to have ischemic strokes, and 10 to 20 have hemorrhagic strokes. So as you note with Dr. Benan's study, that also range was in around between 10 to 20. So it's showing you how vast the problem is. Now we've been talking about early onset, late onset, but usually after a stroke, some of these patients will tend to have a span over that period. So if you take 1 year, that around 40 to 80% might present late. So I wouldn't say that I'm safe if I've had things which are presenting to like a stroke, a seizure, that after the 6-month period I'll be totally free. So you have to follow up. Even some can present after 2 years and the seizures come. And we do other things. You've tested for malaria, you've tested for all electrolytes, and things are normal. But still somebody still gets seizures. Now, the most important thing on this slide is that when we get seizures, these patients have a high risk of mortality of death compared to patients who are not having seizures, who have had a stroke, but they don't have seizures. And then sometimes, even on my ward, on 4B or other medical wards, you've seen what Dr. Matova said in ICU had said, that sometimes we get these subtle seizures. We don't see any clinical manifestations, but then the patient is not improving. And these subclinical seizures sometimes prolong the patient's stay. Not improving. CTs you are doing are not picking much, but at the same time, we are not having any improvement. And if we are not putting any anti-seizure medication or to attend to other needs to control the seizure, then we have a longer hospital stay. Yeah, so early and late onsets usually result from tissue damage once you've had an attack, and 90% of these patients, may have other seizures even after having the initial seizure. So we've seen on the ward or in clinical practice, somebody gets a stroke, he gets a seizure immediately at the time of the seizure, of the stroke. Then it's okay. Even 2 years or 3 years pass. Then after that, of the blue, it gets recurrent seizures. So it does not mean that after 6 months you are free. For the time that you are following, just keep it in the back of your mind. Then patients with late onsets have definitive epileptogenic foci and form stable epileptic networks, which are susceptible to recurrent seizures that we need to diagnose, can be diagnosed as epilepsy. So with these patients, sometimes you can diagnose them as epilepsy because this scarring can be like a generating place. This scar tissue has a different conformity, or it conforms different from other cells. The contents there, the sodium, the glutamate are deranged, and these always are going to cause us to have different points of foci to form seizures. This slide is mainly for us still in learning like me. just remember that the mechanism will still have excitation too much. Sodium moves in the cell, and then also the calcium ions. Then definitely our neurotransmitters, glutamate and aspartate. Because for ischemia, you are cutting off oxygen supply to the brain. So the blood, the cells in the brain receive low oxygen, anaerobic respiration. Hence, you are having the end products of anaerobic respiration, increasing glutamate and aspartate, which are noxious to the cells. Then inhibition is too little. You have low inward chloride, low inward potassium, and the GABA aminobutyric acid, which is our inhibitory neurotransmitter. So with that imbalance, then you are likely to have a seizure. Now for hemorrhage, things change a bit. You have a blood vessel which has ruptured. Definitely you have a blood spill into the brain. So the main component that you're worried about is albumin. Once albumin leaks and gets in touch with the brain cells, either the brain parenchyma is going to induce seizures, either by activation of the transforming growth factor, which I've already talked about. Or we can have iron. Iron itself as HB, hemoglobin is broken down, we get iron. The iron deposition in the cells and on the brain cells also will spike these seizure activities or hemosiderin. So for hemorrhage, it's a different mechanism. So this would happen in our subarachnoid hemorrhage or intraparenchymal hemorrhage. This picture is happening again. It was, but what to note here that once you have hemorrhage, as we've talked, we will have a spillage of iron and albumin and heme, which are going to affect these astrocytes. And then for the ischemic infarct, here you have numerous mechanisms which are going to lead to seizures. So then for the late seizures, you're going to have scarring, angiogenesis, neurogenesis, apoptosis, which are going to lead to the late seizures. And all of these lead to chronic inflammation, then ferroptosis, which is iron deposition, which kills off some cells in the brain. Now, having talked about this, then we want to form a, how do we make a prognosis of our patients, just to know that maybe patient A is more prone to having seizures than patient B. So different models have been used in Europe, mainly in Sweden and in the USA. So one, we have the post-seizure epilepsy ICARE score, which consists of 7 items. Here you're looking at how many days are you spending on the ward. In modern countries, usually somebody with stroke should spend around 4 days, or at most 3 days. 24 hours in ICU or 48 hours, then 2 days of general ward care, then you're discharged. In Mulago and other hospitals, 2 weeks. Average, I would say 1 week, but we are spending between 7 days to around 10 days. 2 days to do a CT scan, then another 2 days to do the renal functions and cholesterol, then treatment will start on day 5. Okay, and 90% we are doing secondary prevention. And we can't do curative because average patient presents after 2 weeks. 2 weeks, that's around 30%, but the majority come after a month. So here you look at the hospital stay, you are looking at seizures, at the time of admission, and this is very dependent on who gives that information. Sometimes we receive patients and we can't recall whether the mother convulsed or the patient convulsed or not. If somebody is about 65 years, intensive care stay, decreased level of consciousness, atrial fibrillation, and respiratory failure. Then there is the CAVE score, which is looking at the cortical hemorrhage, if you have bleeding within the cortex, whether on the cortex or inside the cortex. Then the age, about 65. Then this should be the volume. I think I deleted the V. Volume more than 10 mils of blood. And then early seizures, each is scoring 1 point. And the higher the point, the worse the prognosis. So anybody above 3, then we have a poor prognosis, and we think is more likely to have seizures in the future. Then I think once you interact with the surgeons, they will talk of the select score. And here determining epilepsy 4 is ischemic stroke, which was used in Sweden. So you're looking at the severity of the stroke. Okay, then is it a large artery which was affected? Is it like MC, middle cerebral artery, or there is small artery, depending on what the CT scan has shown, what the report has given you. Early seizures, then cortical involvement, and then the territory of the middle cerebral artery involved. So we know that the probability of delayed seizure within 5 years is around 40, close to half, 50%, if you are scoring more than 7, 8, and 9 respectively. So these are just to guide us how to profile our patients for future, whether to start on medication or not. Now, we've been discussing about treatment, but treatment, usually we don't give primary prophylaxis. So primary prophylaxis means we are going to give a drug to prevent a seizure. If I just have a stroke, I have no seizure, give me a drug and prevent me from having a seizure, which we are doing on 4B, depending on the prescriptions which are coming from emergency. But there's no evidence for that. So we are receiving many patients who are having Rivancera, Keppra, lamotrigine from emergency with just a stroke because the bleed is big or have had a big impact the whole brain or what, and just put me back. There's no evidence. The pitfall is these drugs are going to dampen your level of consciousness. That's one. 2, they are interacting with your other drugs you're giving. 3, sometimes want the patient to be able to eat sober, to sober up and eat or be able to understand the cognitive function. And then the patient comes, is always sleeping. And then when here, because he's not eating or he's sleeping, then you say, if you can inject tube or give him this other drug. So you're just adding a lot of drugs without having evidence. And then when we go to the old anti-seizure medication, our phenytoin, which we use, phenobarbital, carbamazepine, they interfere with the neuroplasticity, the way the neurons connect, so that the patient gets either the transferred information or the movement of the body, and also contributes to that patient's recovery and also cognition. So we'll base our discussion of 2 of the randomized control trials which are done in Europe. This is 2024. And they looked at patients who had stroke in a randomized double-blind study comparing 1 month of sodium valproic acid treatment and the placebo. One group received and the other didn't receive 2 hours after the onset of a stroke. And for primary seizure prevention. So this included 72 adults However, the risk of seizure, and they follow them for 1 year to see if they're having seizures or not. So we note when you look at their relative risk is less than 1. However, those who died and those who did receive seizure, there's no major difference. So showing that whether we are giving primary prophylaxis or not, there's no evidence. So far there are 4 studies, we picked 2. Then another study also compared, was the RCT, double-blinded, which was comparing a 3-day diazepam treatment with a placebo for primary seizure prevention up to 3 months after stroke. And here they looked at 784 adults with acute stroke. However, there was no difference in the risk of post-stroke seizures in both groups, whether in hemorrhage or ischemic. So this cancels our treatment that maybe if I get a stroke, start me on treatment, primary prophylaxis. There is no evidence up to now. So, in conclusion, we'll go with secondary prophylaxis. Secondary prophylaxis means you've had a seizure and now you are treating. So our aim for secondary prophylaxis is to prevent further seizures. When we have further seizures, we are doing more damage to the brain in terms of cognition, in terms of recovery, and also increasing the levels of mortality. So here, the second bullet, we are looking at which drug is better than which. So there's a study which was done in Sweden in 2023 and looked at lamotrigine and levetiracetam, which is kept not specifying the generic. But the good thing with this, they had a better retention rates and low recurrence rates. So if you put me on these drugs, the newer anti-seizure drugs, my chance of having another seizure is lower, and the drug is more likely to control me better than the old anti-seizure drugs like carbamazepine or phenytoin. And in the next slide, we'll look at the drug interactions. So we know that most of our patients who have stroke, they have atrial fibrillation, they have diabetes, they have CKD, name it. It's a cocktail of all diseases, comorbidities. And with these comorbidities, they are taking different drugs. Antihypertensive drugs, diabetic drugs, they are taking renal drugs, they are taking ART, they are taking all kinds of drugs. Now you bring in your anti-seizure drugs, definitely there are going to be lots of interactions. And as a good physician, you want to limit the number of drugs. A good physician gives fewer drugs. The fewer drugs, the better. It's like in an exam, the shorter the explanation, the better. The longer the explanation, then you are worthy. If I'm asking you which route leads to fairway, and you can't say it in one word, then you tell me, you see, you get out here, then you see the traffic lights, go down, then go up, just tell me the road, and then you're at fairway, okay? So this slide is a bit crowded, but we'll just see carbamazepine, phenobarbital, phenytoin, and phenobab they induce. But they have here they also reduction in cholesterol transformation, their total cholesterol. So they are going to effect on people in post-stroke epilepsy. So you have total cholesterol and triglycerides are going to increase. So I might be treating my patient with aspirin, ischemic stroke, but my cholesterol keeps on going up. So you have to do blood tests. Then vitamin B might also go down, and homocysteine goes back. The higher it goes up, the higher the risk for you to have a recurrent stroke. So you need to test. Then when you look at other statins, here they might increase, you are giving statins, but they might also decrease the statins. And total cholesterol are going to go up. And this is what is happening. Most patients stroke, you are adding a statin. And then I'm going to add an anti-seizure drug, maybe carbamazepine or phenytoin. Then we fight with the statins. I mean, the cholesterol going down. In actual sense, not going down. But I'm treating myself as a doctor. Okay? Anticoagulants, the new oral anticoagulants, rivaroxaban and apixaban, their effects going to decrease. So you need to blood test. So these are some of the, if you had many patients, these are good studies to do. You would be a world breaker where you're doing the effect of drugs to anti-epileptic, and surely the New England Journal will take you up when you publish. And then we are looking at antihypertensive, the effects, so blood pressure is going to increase. We see many patients with post-stroke blood pressure 180, they come to the clinic, he's on just continue carbamazepine, phenytoin, and then you're fighting to put the blood pressure out, but it never comes to the mind that, oh, maybe this drug is affecting, interfering. So we have to think now 360 about that. So people on sodium channel blockers, because here phenytoin interferes with sodium channel, so you increase your risk of AV block and sinus bradycardia, and then your risk of embolism. So then there are those unknown things. Then when you go to carbamazepine, increase in ADH, so increase in blood pressure or congestive cardiac failure. So you have to monitor the blood pressure and ECG and echo. Phenytoin still the same, blood sugar, A1-APC. So hemoglobin, HbA1c, you have to, especially if somebody has diabetes, because it's going to increase your insulin. And then sodium valproate is going to increase on insulin secretion. This week, seeing a patient who was complaining of, he's being treated for headache, but it's on a different drug. It was on carbamazepine, seizures. And he was complaining of hypoglycemic episodes, like at between midday and half past midday. Even though he takes breakfast, he takes tea at around 10:30, but he's on carbamazepine, a strong dose. And I was really puzzled. But only when you keep reading, sometimes medicine has to humble you. And it's the temperature which is causing insulin increase. So you never say that you know it all. So these things happen. Sodium valproate, you might get one patient in maybe 10,000, and then just remember that it happens. So that's why we are advocating use and newer drugs. Not that they are very more expensive, but they are more side effects. They are gentle in the side effects for the patients. Okay. Yes. So Dr. Isaac was discussing, and the question came up of statins. Yeah, statins are used, but it's not a standard of care because there is no evidence. Evidence, we are talking of evidence A, evidence B, and evidence C. Evidence A meaning proven and it works, and there's evidence that it works. Evidence B, yes, it works, but you don't have a lot of papers done or research. Evidence C, it works. If you find me standing by the roadside, maybe, or driving on the roadside, yes, sometimes it could work for me. But on a good day when they get you a traffic officer, it doesn't work. Okay, or if you make a U-turn, you could make a U-turn and do something, it works on that particular day. But it's not evidence that it always works, that's a joint that we are going to pass. That's what it means. So, 6 studies have been done in Europe, 4 in Europe, 2 in the US. And they are investigating the effects of statins to prevent the development of seizures. And yes, the statins lower the risk of seizures, as we see by the odds ratio, 0.6, and also early seizures by 0.3 respectively. Okay. However, the possible mechanisms, so they include anti-inflammatory effects on the vascular endothelium, reduction in the free radicals and also increasing on the GABAergic activity activation and also membrane stabilization. However, we don't have enough randomized data or studies to say that this is the standard of care. That's why it's done by preference. Individual patients, it's individualized, not that it's among the treatment guidelines that it has to be done that all patients with post-stroke put on statins. No, there's no evidence. Okay? Yeah, and that's bringing to the end of the presentation because previously it had been said by Isaac and different people. So just to wrap up what was being right. Thank you.
Yes, thank you very much, Mr. President of the Neurology Federation of Uganda. At this point, we welcome questions. Yes, feel free to ask anything and you get an expert opinion, an expert answer, an answer from an expert. Any questions? Okay, that means everything was very well understood. Thank you very much.
Thank you very much, Dr. Kadu, for this elaborate presentation. Now, my question is, if a patient gets a stroke, say for example, ischemic stroke, and they have an underlying dyslipidemia, that is one patient, then the other one, you do a lipid profile and it's low. So, according to the explanation, you said that statins are not indicated as part of the routine management. So, do I still give this one that has a dyslipidemia? Do I still give them a statin?
Yeah, definitely the one that is lipidemia give a statin. So they were basing on the normal stroke care guideline. Okay, like you get a acute stroke or hemorrhagic stroke using the American either Heart or Stroke Association guidelines, you give, you treat the lipidemia. Then, now regarding the one who doesn't have, and also my chances of his clinical presentation, the different features, maybe as a hemorrhage, the hemorrhage is small and he didn't have a seizure, and there are no risk factors for that, then if it's okay, then I won't give, then just monitor. Yeah. Prof. Kadu has something to say.
You need to remember, or you need to stratify care according to your patient. So if they don't have a dyslipidemia, no seizures, you don't give a statin. Whereas research has shown that they may be a benefit in reducing the early seizures or reducing the risk of developing post-stroke epilepsy. You don't have a justification to prescribe it. Okay? I know there are studies to use them because of the drug interactions and the poor safety profile associated with them. If you are to use the newer generation, Keppra, Lamotrigine are better. They have a much better safety profile and a reduced drug interaction. Your first generation drugs interfere also with anticoagulation, especially if your patient has an ischemic stroke and you're giving it anticoagulants. So yes, Keppra and Lamotrigine have been explored. They are associated with a lesser mortality risk and fewer seizure recurrences. I think Martin has highlighted the primary prophylaxis, not recommended by any of the organizations or associations, since the risk of seizure recurrence is low. Remember, why we give anti-seizure medication is to prevent another seizure from occurring. The one which has occurred, there's nothing you can do. So if someone has stroke, they get a seizure, recommendations, you don't need to give prophylaxis, okay? But if they get another seizure, then there you can go ahead and do what? Give secondary prevention. And newer generations. I think the other things have been highlighted. Don't forget this in the scores. There's select 2-0. There's select, then there's select 2-0. Select 2-0 is the newer one, where they added cortical superficial siderosis. He talked about hemosiderin. So for patients who have cortical superficial siderosis, was added as another marker to increase the score of prediction for occurrence of seizures. Of course, there are gaps. It's difficult to know which patient is going to develop seizures, so risk assessment is important. It's also difficult to know which patients will require long-term treatment. Usually, the current guidelines state that if you initiate anti-seizure medication, for whatever reason, maybe a patient had seizure recurrence, got one seizure, got another one, you initiated anti-seizure medication. If you give your drugs for 2 weeks and your patient has not had a seizure, you stop. Okay? So predicting one who's going to develop long-term requirement is also not clear, it's difficult. Then of course, selecting the appropriate anti-seizure medication, you have to stratify that to your patient. But we recommend the newer generation, not the older one. Majority of our patients will give phenytoin, phenobarb, carbamazepine. Move from that generation, move to the newer generation, please. Thank you.
Yes, yes.
Maybe just to highlight, I know you're closing. We still have support, at least at 30 years. Maybe if you go and see the first years, we are going to put out a call, I think in June or July, for supporting master's research. It should be touching on epilepsy. Okay? So in whatever questions you generate, there should be some epilepsy questions for what you're trying to, yeah, for pediatrics and for adults. So the call should be coming out sometime in June. So look out for it.
Thank you very much, Prof. And I think before I go into the next presentation, I will still ask you another question. So we have very many neurologists in the making here, and they would maybe want to hear a little bit more from you about the pathway towards that side. Yes, you could talk to us in your capacity as our Dean, School of Medicine, as well as a very distinguished neurologist. So what are the opportunities? Yes, you've already highlighted one that's coming up, and I encourage our first years to take it up and write and ask for that money. But that aside, what are the other options? What are the other opportunities? The third years we're finishing and they're still like stem cells, they're not yet differentiated. So how do we encourage them to differentiate into neurology? Yes, and also we have our junior house officers who are not yet decided whether they will do obs and gyne, the 1%. So how do we bias them towards neurology so that maybe 10 years from today, we could have a full house of neurologists? Thank you.
Thank you. So for we are developing a neurology fellowship, following, of course, pediatric, oncology, hemato-oncology. So we are working on that through the university. I don't know, maybe it has focused on adults since it is under the Department of Internal Medicine. It hasn't included pediatric neurology. It will be, it's supposed to be a 2-year fellowship after your master's. So that one is in the pipeline. I think when the other fellowships come. We also support neurology training outside Uganda. Currently, we selected Chaze, Isaac, Andrew. So Andrew Chaze, I think, was selected by the department, and he should be going, I think, in August, for a couple of months, as he sees what is being done, learning a few things about neurology, then probably come back and do a fellowship and grow through the track. So those opportunities are available. We have collaborating institutions here, UCSF, UVAS, Global Health. So those ones come and we support. The only challenge we have now is the issue with the visa, which requires you to pay a bond. University does not commit to pay your bond. So sometimes those are things which we are trying to solve and address. Hopefully we'll be able to solve them, but opportunities are there. So we have partners where we can send. I know we are going to send someone for neurology, GI, renal, the other different specialties, so, and pulmonology. So be on the lookout when we make advertisements for such opportunities. Okay? Depending on what specialty you are interested in. Yeah, I think that's all.
Okay.
Thank you very much for those great insights. I believe we are charged and we are going to follow suit. I don't know if anyone of us has any questions to our teachers. If you have, maybe this will be the best time to ask, because after that we are going to welcome our sponsors who made this possible. Yes, we are in a 5-star hotel, so someone has paid for that to happen. And I think at this time I'll invite them to talk to us about their products. So let's give them some bit of time. Thereafter, we shall take a group photo and head for lunch. Over to you, Mr. Natrinda Arnold, to take us through this role of vitamin B12 in stroke.
Thank you very much. Thank you very much. Good afternoon, ladies and gentlemen. I stand as Arnold Natrinda, as a field supervisor for Troika Pharma. And in the extreme is Mr. Ravi, our country manager. Is new. Yes, is new. And thank you, Dr. Kadu and others for welcoming Troika to be in partnership with you. And don't take this as something simple, but thank you very much for that. So I'll just share something a little bit snappy. Let's say that the role of vitamin B12 in stroke. As indicated, there's a burden on those low-income countries that we tend to usually have. Most of the patients have stroke. About and some of them even result to death. Some of them, 89% of them are stroke-related burden. Then 87% of the deaths that occur would also be due to stroke. And to just make it a little snappy, like I told you, that is the distribution about the deaths that we've been saying, but about most of them in low-income countries, usually the deaths that will occur, some of them usually be due to the income status also being one of the factors that determine that. But what are the risk factors, let's say, for stroke? Usually, this is what are highlighted. First of all, we say high homocysteine levels, or hyperhomocystinemia, vitamin B12 deficiency, high levels of LDL cholesterol, or high fasting plasma glucose, ambient plasma matter, smoking, kidney dysfunction, a high BMI, low physical activity, high alcohol use also, diet that is low in fruits or vegetables, and diet that is high in sodium. Those would be some of the risk factors for stroke. Now, like the topic had before, we shall just close it on the vitamin B12. As you see on our curve there, the pathway for homocysteine, somewhere there just above the homocysteine levels with vitamin B12 is very crucial to convert homocysteine to methionine. When you don't have vitamin B, when one doesn't have vitamin B12 within the methionine levels, or homocysteine levels will build up, which will lead to the first risk factor that we had, which is high homocysteine levels that will also lead to stroke. So with that, vitamin B12 is very crucial, very essential, because it functions as a cofactor for DNA synthesis and methionine generation. Like I said, I wouldn't want to replicate also what you have been also sharing here. Just cut to the chest, just to say that this is that low vitamin B12 is an independent risk factor for ischemic stroke. But the current formulations, I know sometimes you've been also usually, some different formulations have been available in the market in terms of treating it. So, and the different formulations, some of them could be oral, but the oral usually has its own limitations. What are the limitations? The first one, usually there will be passive absorption, which is the absorption here, they're trying to say the absorption usually will be very minimal. What does that, it also depends on the dosage usually of the tablets that usually are manufactured. Most of the tablets that are in the market, some make about 50 micrograms, some make about 100 micrograms, very little for someone to take orally and be able to replenish the vitamin B12 levels. Then also there is a challenge, or there's a burden of someone having to swallow the tablets always, every day. With that, it also increases non-compliance. Then lastly, also the cost-to-benefit ratio. If one has to swallow a tablet every day, there will be a challenge of them affording to swallow. Sometimes you may write a prescription, but you will find that some patients are unable to still comply by swallowing that tablet every day. For example, if you've given them 6 months, if you've given them 3 months, swallowing every day may be a challenge. If apart from it being just a burden itself. So with this, the American Academy of Family Physicians stated already defined the normal levels of B12 are supposed to be at least above 400 picograms. That is the normal. And then sometimes with those with deficiency, they will be below 150. And where most usually lie will be within the subclinical cobalamin deficiency levels. That is between 150 to 399 picograms. So the reason, and some of the literature also has stated it that someone has to have about 400 or above 400 picograms so as to support the neurological health. That is within also one of the books, also one of the journals that also highlighted it as that. Then, like I said, also to cut the chest. One also stated the stuff that vitamin B12 is stored in the liver and decreases the likelihood of also vitamin B12 deficiency, as we will also know. Then the one book of the hematology, the clinical laboratory hematology also says that oral vitamin B12, it takes, if one swallows oral vitamin B12 for long, that was the study that was done, and found that about the average mean was about 286 picograms within 30 days. So that is still below, or lies within the subclinical levels of vitamin B12 levels. So with that, we still find that it's having oral vitamin B12 would be a challenge. Then the dosing schedule is also one of the books also highlighted that vitamin B12 injection supplementation on alternate days actually will usually replenish the vitamin B12 levels in the patient. So it highlighted it would be the most convenient way to also treat vitamin B12 deficiency by using IM vitamin B12 injection. However, there is a challenge with the vitamin B12 injection because it comes along, it has to be augmented also together with cobalt. And cobalt is very painful. So if you give a person a vitamin B12 injection, a prescription, so that means they need to utilize it on alternate days. They need, let's say, like if today's Friday, if they go for one injection today, that means the next injection they'll have to get it on Sunday. But because of cobalt also, it will be very painful to them. This also affects the compliance. So the injection, if you've been keen to try to follow up your patients, you find that they'll get the first shot, second, but the other subsequent doses, they tend to also have a challenge in continuing with that dosage because of the pain, one. Then secondly, also the cost of having this injection. Because when you prescribe for them, they have to also look for a specialist to be able to give them this IM injection. As you know, someone cannot easily, or not everyone can be able to give an intramuscular injection. So with that poor patient compliance, in 2019, Troika was able to innovate another route for administration of vitamin B12. And this is nasal B12 spray. And nasal B12 spray, we added together some technology that we had partnered also with some other pharma companies in Germany. And this was nasal max technology. Why nasal max technology? It is able to, when a patient pumps this vitamin B12, it is able to give it in a metered dosage. That every time they pump, it will give 0.01 mils of vitamin B12. And that would be equal to 250 micrograms of vitamin B12. So the route that Troika opted for was the intranasal route. Because of the tissue there, once something is water soluble, it's able to be absorbed so easily. So nasal B12 spray is methylcobalamin nasal spray that is 250 micrograms per spray and very available. So it gives you assured absorption and painless treatment. As we saw prior to the different regimens that were looked at, the tablets having the challenge of the dosage and the injection having the challenge of pain, this comes as the other solution that will be virtually painless, nasal B12 spray. As it's also showed that from a pharmacokinetic study that we find that also that when you compare it to the injection, you will have actually merely also no difference also when you compare it. The single use of nasal B12 spray achieves a Cmax that is as equivalent as the vitamin B12 IM injection. Also, as we stated in the first week, patients will have, on the first day, when they administer, about an average, would make this have an average of 123 picograms. Then after a week, they'll have about 530 picograms. Then further, on the second week, as they administer, they will have 719 picograms. That was the average that we found out in most of the patients. So with that, you'll find that actually, your patient is able to quickly lift up their levels within the first week. So they'll be at least safe in those levels. So nasal B12 spray being the solution in here. And this is just one video that was just here to demonstrate on day one what would happen to the liver, replenishing of the levels. As you may see, on day 3, as I told you, it is also given on alternate days, like the injection. Day 7, day 19, then to the 13th day, which is the second week. You will have a good build-up of vitamin B12 levels. Just to the left, I just just wanted to emphasize this, that what really had brought us, and just wanted to illustrate to you. Nasal spray looks like this, as many of you have probably have seen within the hospital. And for those who have not seen within the hospital, I'd like to just take an opportunity to demonstrate to you. Nasal spray comes with this. So it comes also with a seal. So once the patient receives this, all they need to do is to first open the seal. Then when they open this, on the first side, there are some numbers that are there. It shows there's 1, 3, 5, 7, 9, 11, and 13. So even for someone maybe who hasn't gone to school also, this one was supposed to help them as the dispenser is giving to them, they can be able to explain to their patient, just in case they've forgotten what they've been able to give them. Or sometimes because of the patient load or the burden that you may be having in the clinic, explaining may be a challenge. But with this, it also makes the work of the dispenser very simple. So with this nasal spray, so in the first time, they may need to prime it. They will need to prime it because we add no preservative in this nasal spray. So you need to prime it in the air by expelling the air bubble. So with 1, 2, 3, 4. With that one as a definite spray. So they will turn to the right nostril and spray once. Then also to the left nostril and spray once. And that will be enough for the day. Then they can, what will they usually advise them? They have to, again, put this nasal spray back in its box. If you notice, the box is also dark in color because vitamin B12 is light sensitive. So with this, then after they've applied it, they just need to pump and then just put a tick on day 1. Then they know that the next day they will miss out. Then they'll use maybe today's Friday. They've applied Friday, then they'll just need to miss out on Saturday. Then they'll use on Sunday. Just need to use it on alternate days for 1 week. Then after 1 week, they'll just need to maintain once a week for a month. This was innovated so as to reduce on the challenges that we have seen before of injection and the tablet to make the life of the patient very simple. So that was Troika presentation, and just trying to share with you the role of vitamin B12 in patients of stroke. If there's any quick question, any query, please feel free to share now.
Just the page you have.
Just maybe as you share the questions, we have a quiz here for you, and there are some prizes out there that are also made for you for this conference. So we'd just like to share with you, all of you that like to share, and those who will have gotten the mark, so those who will pass with what we presented here today, will win the prize today. Thank you very much.
Wow, thank you very much, Troika. A big round of applause to Troika. And thank you very much for sponsoring this. We've walked a long journey and we are continuing to work together. So thank you very much. About the quiz, may the best candidate will help you. We need more than one winner, right?
Yes.
Many prizes.
3.
3. Okay.
First, second, and third.
Okay. So may the best candidate win. I hope you have enough papers.
Yes, we have enough.
And what is the inclusion criteria? As a consultants, part of it or they're out? Because I'm already seeing some threats here.
The doctor should decide.
Okay, so I think it will purely be for the GHOs and the SHOs. Okay. So I think we shall also, when we finish attempting the quiz, we shall take a group photo. I'm sure Dr. Mubino will need that photo. Dr. Mubino, I don't know, Dr. Mubino, I think you should come and tell us about our website. We have a website. We have a website for the Neurology Federation of Uganda. There are any opportunities for us. I mean, which information do you want us to know? How best can we support this growth? Yes, Dr. Mubino will talk to us as we attempt our quiz. Thereafter, when we finish our quiz, we shall come and take a group photo. I think there's a bit in the background. We shall put some seats here, our consultants will sit and we shall stand behind them. We take a photo, and Dr. Ngiri is going to tell us where he will post our photo after it has been taken. Meanwhile, now your Sanaiban ambulances should be getting, ready. Yeah? I hope our lunch is ready, because thereafter we should be going for our lunch.
Yes?
Question. I need to answer this.
Yes.
Yeah, I'm coming back. I'm just something good.
Our dear guests, our consultants, the neurologists in the house, said all you're very welcome. Yes, I'm Dr. Peterson. So we also thank Troika, really. So we thank Troika who have funded this. So it has been a really long journey with the organizers, Dr. Mubiru and Dr. Sechanji. So really thank you very much for the great job. So it is the first conference, so a lot of things were to be from scratch, including a website, a mail address, all social media platforms, WhatsApp, Twitter. Really an active association like this should be having all those. So we are pleased to inform you that we have a website. We are going to share the details. We have a website. We have a Twitter account, and we have a mail, effort mail. So we're really pleased for that. We continue to thank Baker for funding most of the things. Yes. Thank you very much.
Okay, even before the time at the last. Yes.
Yeah, yazikidde. Anti egamba yazikidde. Aliddeko mu live very positive.
We are going to arrange for a photo here. Come again, next.
Kusajobo.
Before we go, we have lunch. Yes, we getting our lunch ready. But before lunch, we should be gearing up for a group photo, which I think we should take from right here. So our consultants will sit here and shall sit right behind them and take our group photo.
Arnold.
Okay, so let's come for a group photo, comrades. Group photo.
Yes, yes, yeah. Arnold.
Group photo. We shall reserve the seats to our seniors and we shall stand behind them. Shall we eat? I think we may need to extend a little bit the other side. There's more space the other side. Yes, that side.
Yes.
You want to smile with federation. Okay, thank you very much. You've been a great audience. And I hope now you know that you have an MC for hire. Yes, if you have a wedding, intro, for barriers, no? For barriers, we are not there. Well, I think we can go for our lunch.
But then this goes on to, yeah. Yeah, it's ready to announce.
next time one we can
I know what you're
While